Welcome. My name is Joe Brogan, one of the hospitalists here at Duke Hospital. Today we're going to be talking in our next lecture of the Duke Core Curriculum series. Today we're going to be talking about sepsis and the inpatient diagnosis and management. We're going to start off fairly basic and discuss the definition of sepsis, the epidemiology, pathophysiology, and microbiology of sepsis, and then get a little bit more into the nitty-gritty details of the clinical criteria of how someone meets sepsis or severe sepsis, septic shock, and how we best manage it. So the fundamental question is what is sepsis? The exact definition is debatable. One of the papers that I was able to read discussed historically sepsis has been actually around since the time of Hippocrates. Back then he claimed sepsis was the process by which flesh rots, swamps generate foul airs, and wounds fester. It was not until sort of germ theory came around that it started to be believed that sepsis was a condition of blood poisoning, as noted by the thought of small microbial infections. When we came around to the mid-1900s and the invention of antibiotics, or discovery, I guess you should say, it became clear that even with full eradication of microbe, there still was a significant amount of damage that would happen to patients, suggesting that the host or immune response played equally a large role in the pathogenesis of the condition. But today we understand sepsis over the last 20 or 30 years to be a severe systemic response that our body does have, which leads to organ dysfunction, hypotension, and even possibly death. And it's important to note that early recognition and treatment are paramount to improving survival in this condition. Sepsis is actually a very common condition. Around 2% of all hospitalizations are billed as being related to sepsis. That equates to around 750,000 cases per year. And actually a sizable amount of total hospital costs. As of 2011, it represented about 5% of total hospital billing. Initially, this was something that we saw mostly in our ICUs, and in all honesty, most of the literature supports management with ICU monitoring and variables. But it is becoming a more common condition encountered in our general medical services. So being fluent in the treatment and management is important to hospital medicine. Some have noted that the incidence of sepsis has nearly doubled in the past 2000 to 2010, and the true incidence of this condition is actually unknown. Some people purport that this increasing incidence of sepsis may be attributed to our aging population, the increasing level of comorbidity present in our patients, but also favorable coding in terms of reimbursement. So that is a topic of hot debate currently. Clearly, it's a prevalent condition, and it's something that is potentially life-threatening, so it is a topic that we'll investigate further. Moving on to pathophysiology, I included here a Venn diagram that's actually from the first set of guidelines that came out in 1992 discussing sepsis and what it means. I think that this is a pretty nice illustration of the overlap between infection and systemic inflammatory response. Infection being related to a microbe and systemic inflammatory response being the host response to that infection. It's not until these two overlap that we get the clinical syndrome of sepsis. The large circle here, bacteremia, shows that primarily bacterial infections are going to be what causes sepsis. Fungemia is possible, as well as other infections, but really it's bacterial infections that are the main targets for our therapy and the main drivers behind the syndrome. I also like how they included pancreatitis, burns, and trauma over here for systemic inflammatory response, as not only infections will cause an inflammation response that results in physiological vital sign derangements, etc. A more recent review gives us a little bit more nitty-gritty detail on the actual cellular microbiologic level, what is going on during sepsis. What we know is that when someone develops severe infection, there's both a activation of a pro-inflammatory and an anti-inflammatory response. Things like cytokines and other sort of inflammatory markers help to activate things like our complement products, our coagulation cascade, our neutrophils and other T cells, as well as host factors, our environmental factors, our genetics, our age, our other illnesses that then, sort of mitigate and try to downregulate the anti-inflammatory response. At a basic level, we know that it's this sort of dysregulation that causes a lot of what we see manifested in the systemic inflammatory response syndrome. In addition, the coagulation cascade plays a large role in the metabolic and pathophysiologic derangements. It's not until we have severe sepsis, which we'll get to later, that we start to have end organ dysfunction. And this slide here, which was also sort of the follow-up slide to the previous, shows how we have activation of the clotting cascade leading to thrombosis. We have various downregulation of sort of the tight junctions and intercellular connections that lead us to have capillary leak and the development of distributive shock, which ultimately leads to tissue hyperperfusion. And it's really that this tissue hyperperfusion and decreased tissue oxygenation that results in our severe sepsis and end organ ischemia. So that's just a short, sort of brief discussion on the complicated pathophysiology. It is important to note that although we know quite a bit about this on a sort of basic science level, there have been a number of trials looking at trying to target specific facets of these cascades, and a lot of those studies have been negative in terms of us being able to restore the non-septic state. For instance, steroids oftentimes have been trialed in patients who are septic, thinking that the inflammatory response is what we need to mitigate to improve outcomes, and actually has never been shown to be helpful. Another famous medication that was used in the past for sepsis and severe sepsis and septic shock was activated protein C, which was designed to act on the sort of thrombotic complications of sepsis, and that also was taken off the market due to negative effects. So this is a very complicated process. We don't have many targeted therapies, as we'll get to, and prevention before it gets so severe is paramount. When we talk about the microbiology of sepsis, it's actually quite evenly distributed between gram-positive, gram-negative isolates. In all honesty, blood cultures are positive in only around 33% of cases. And a lot of times we go without knowing exactly the organism that caused it for a variety of reasons. Based on, one study that was sort of a multinational study that looked at 14,000 ICU patients, gram-positives accounted for around half of the cases of sepsis, Staph aureus and Streptococcus pneumoniae being the most common gram-positives. Gram-negative rods accounted for around 60% of cases. E. coli, Klebsiella species, and Pseudomonas aeruginosa also were the top three. And fungus were around 20%. I know these numbers don't add up to 100%. There's, that elevated number can be explained by polymicrobial bacteremia. Nevertheless, as you can see, bacterial infections account for the majority of cases, but fungus should also be considered and has been identified as an increasingly common cause of sepsis. So we're going to move on to what I would call the classical clinical criteria for sepsis. This has long been an area of testing for medical students and residents, the 4 criteria of systemic inflammatory response. And these are best noted as a temperature greater than 38 degrees or less than 36, noting that hypothermia is oftentimes a stronger negative prognostic factor than is actual true fever. A heart rate greater than 90 beats per minute, a respiratory rate greater than 20, or alternatively a PaCO2 less than 32 if you have a blood gas, which makes sense that would be about the same in most patients. If you're breathing more than 20 times per minute, you're going to breathe off CO2, probably less than that level. A white blood cell count greater than 12,000, a white blood cell count less than 4,000, or 10% immature band forms, all can allow you to meet one of or more of those criteria. It is important to note that there's no gold standard definition, test, or validation for the diagnosis of sepsis. These are the original criteria that were laid down in the original consensus guidelines in 1992, and they were derived from available basic science data, proven clinical trials, and a decent amount of expert opinion. So after describing the criteria for systemic inflammatory response syndrome, to meet the criteria for sepsis itself based on the classical criteria, all you really need is SIRS plus an infectious source. So whether that's a urinary tract infection, a pneumonia, a soft tissue skin infection, some sort of intra-abdominal process, whether that's an infectious colitis, ascending cholangitis, cholecystitis, etc., that would qualify you, as we know it now, as sepsis. Moving to sort of the next level, or a more increasing severity, is what we call severe sepsis. This is sepsis plus organ dysfunction. Organ dysfunction can be manifested in several different ways. From a CNS standpoint, delirium or confusion. From a cardiovascular standpoint, hypotension, elevated lactate, which is, a surrogate for hypoperfusion, septic myonecrosis or NSTEMI. You can get hypoxemia due to ARDS from sepsis, acute kidney injury, elevated liver function tests such as an elevated bilirubin. Thrombocytopenia less than 100,000 is commonly seen in sepsis. the absence of bowel sounds or paralytic ileus, and even disseminated intravascular coagulation are all possible manifestations of end organ dysfunction. And finally, septic shock, which is sepsis with associated hypotension unresponsive to fluid challenge. It is important to say that septic shock and a lot of times severe sepsis will be managed in the ICU. However, we do see a fair amount of patients on the general medicine floors that could meet criteria for severe sepsis based on the end organ dysfunction. Severe sepsis is also noted to be associated with an accelerated physical and neurocognitive decline in those that survived a hospital discharge. So understanding those when people meet this criteria does have some prognostic implications. And furthermore, predictors of development of severe sepsis are sometimes or oftentimes include extremes of age, males, and African American race. Other supporting criteria that we have that may suggest that your patient has sepsis. So in the first 24 hours of hospitalization, if they have significant edema or positive fluid balance, that can sometimes be an indication for that your patient is septic. Hyperglycemia greater than 140 milligrams per deciliter in a patient who does not have diabetes can be a signal sepsis. Insulin resistance is actually quite common in the septic state. Other lab markers that have been elevated are plasma C-reactive protein elevation and plasma procalcitonin elevation. I do not see those used very commonly in the diagnosis of sepsis in my practice, but have been potentially investigated as markers. Until recently, the definition of sepsis had not really changed in about 25 years, and shortly before the writing of this lecture, a new consensus panel had released guidelines to suggest a more refined definition of sepsis. In February 2016, a group which sort of changed the name of the sepsis sort of guidelines from Surviving Sepsis Campaign to now Sepsis 3, meaning the third update for sepsis guidelines. They basically redefined sepsis to be a life-threatening end organ dysfunction caused by a dysregulated host response to infection. In this setting, severe sepsis is probably what we would consider to be sepsis based on their recommendations, whereas how we think about sepsis right now would not be considered sepsis. As the criteria currently stand, many patients still will be admitted under the classical label of sepsis who may not actually have what they're implicating as sepsis. Whether this new guideline will affect clinical care at this point is not clear, because it has to have significant buy-in from the community and the challenge of having to re-educate physicians who have been taught sepsis as the classical criteria for at least the last 25 years. This was released by a joint task force between the Society of Critical Care Medicine and the European Society of Intensive Care Medicine. On the next slide, we're going to look at what they suggest we use to determine whether someone has sepsis, and they recommend the Sequential Organ Failure Assessment Score, which is also known as the SOFA score. And as you can see here, they would define sepsis as anyone having a score greater than 2, or anyone that has let's say they have a baseline SOFA score due to their comorbidities of 2. If it changes by greater than 2, they would meet criteria for sepsis. But until that point, they would not. And as you can see here, reviewing this chart, that there are actually very few of the classical criteria here. Really, the only thing that's anywhere close are respirations. and that sort of is a PaO2, FiO2 score. As you can see here, very few of these criteria are things that we tend to look at or monitor in a non-ICU setting. So again, these new guidelines would sort of tilt the balance back towards sepsis being more of an ICU level of diagnosis as opposed to a general medical floor. But nevertheless, the 6 main characteristics of the SOFA score are a PaO2 FiO2 ratio, platelet count, liver function, as noted by Billy Rubin, blood pressure, the Glasgow Coma Scale, and urine out versus creatinine. And this is the general algorithm that they suggest. If you have a patient with suspected infection, an ED provider would most likely perform what's called a Q-SOFA or quick SOFA. As noted before, the SOFA doesn't have many variables that would be readily used by someone at first contact with the patient, because they would require extensive lab testing and central lines and all of that stuff. So the Q-SOFA basically takes the 3 variables that are something that you can look at bedside: increased respiratory rate, a mental status change, or a decreased systolic blood pressure. And if you had a Q-SOFA greater than 2, then you would sort of get a more extensive workup for end organ dysfunction, a true SOFA evaluation, and meet criteria for sepsis. Nevertheless, that is sort of an introduction to where clinical care may grow in the future, but at this time it's a little early to see if this is going to affect clinical care as we know it. So we'll move on to sepsis and the therapy for sepsis. And this can be broken down into really 3 main criteria: fluids and vasoactive drugs, or restoration of hypoperfusion, infection control with adequate antimicrobials and source control, and mainly general measures. In terms of initial fluid resuscitation, one of the buzzwords that we have been taught is what's called early goal-directed therapy. As part of the Surviving Sepsis campaign bundle, 6 hours is a number that you want to remember. At all times, whenever we have potentially hypotensive patients, it's important to ensure that we have adequate intravenous access. And so, 2 large bore PIVs at a minimum are what you would want to sort of consider in a patient that has evolving or full-blown severe sepsis, septic shock. Within the first 6 hours of presentation, fluids are the mainstay of therapy. And we usually pick crystalloid. Crystalloid has been shown to be, crystalloid and colloid offers no benefit as compared to crystalloid in most studies. And so typically we go for something like normal saline or lactated ringers. We have a number of goals that we should achieve within those first 6 hours. A mean arterial pressure of greater than 65, urine output greater than 0.5 mils per kg per hour. Those 2 probably can be monitored closely in the general medicine floor. The other 2 criteria here that are part of the Surviving Sepsis bundle are central venous pressure of 8 to 12 millimeters mercury in a non-intubated patient, central venous or mixed venous oxygen levels. Those are typically measured when someone goes to the ICU and has like an IJ or a subclavian central line placed, at which those values can be monitored appropriately. So those aren't things that we would follow on the general medicine floor, but I guess the main point is that you need to give aggressive fluids in this condition. Persistent hypotension despite appropriate fluid challenge is a criteria for initiation of vasopressors, and we typically consider that to be around 30 mils per kilogram. So a lot of times we admit patients to the general medicine floor who briefly achieve hemodynamic stability and then recrudesce into hypotension requiring more fluids. in a 70 kilogram male, that would equate to, or a female, whatever, it would equate to around 2.1 liters of fluid. So, it's never the wrong call to say after 2 to 3 liters of fluid with persistent hypotension that this patient may need to escalate to the ICU for initiation of vasopressors, and that likely is the right thing to do. Lactate clearance has been shown in some trials to be equivalent to measuring the central venous O2. A clearance of around 20% over a course of 2 hours does typically suggest restoration of perfusion, and that does not mean normalization after 2 hours. It just means an improvement. A lot of times patients have a lactate greater than 4 in this condition, and so improvement of 20% is a lot of times what people look for. The caveat to all of this is that the ability to tolerate aggressive amounts of fluids depends on your age and comorbidities. An 18-year-old with pyelonephritis will be able to tolerate, high dose IV fluids better than someone that has a condition that would put them at high risk for cardiogenic pulmonary edema, such as low cardiac output heart failure or diastolic heart failure. Other patients that have low blood pressures at baseline, end-stage liver disease, those patients with low albumin, they may not tolerate crystalloid that well. End-stage renal disease patients who aren't able to manage fluid and oftentimes are volume overloaded, those patients represent unique challenges. Oftentimes our strategies are to do smaller boluses at a time, 250 to 500 cc's, with frequent reevaluation and blood pressure. Again, a lot of times those patients can be a little more difficult to manage in the general medicine setting, so consideration of transfer to the ICU if they don't have much room or for more fluid or developing hypoxic respiratory failure should be definitely considered. Moving on from talking about the fluid resuscitation point, infection diagnosis and control is also paramount to therapy for sepsis. Cultures as clinically appropriate before antimicrobial therapy are generally recommended. However, if obtaining the appropriate cultures like blood cultures is going to significantly delay the administration of antibiotics by greater than an hour, then go ahead and start the antibiotics. You should also consider promptly performing imaging studies as necessary. So if you're worried about pneumonia, chest x-ray, if you're worried about an abdominal abscess or cholecystitis or something of that nature, an abdominal CT, and so on. Administration of intravenous antibiotics per guideline should be given within 1 hour. Additionally, initial antimicrobial choices, although we're not going to get into extensive detail regarding antibiotics, they should be directed towards all likely pathogens. So common initial therapies, a lot of times coming out of the emergency department, patients will already be on vancomycin, which is, as broad as we really can get. Most people will be covering for gram-positive coverage as well as gram-negatives, although that's not always necessary. It's very clear the source. If it's very clear that a patient has community-acquired pneumonia, that treatment for community-acquired pneumonia per our CAP guidelines is okay. It's particularly important if, to be on very broad-spectrum antibiotics in patients that potentially have multiple sources. Well, they have evidence of a cellulitis, and they also have an indwelling line, and they have an infiltrate on their chest x-ray versus, an unknown source that we have no idea what their source is based on history and examination and initial workup. Those patients should be, most suitably covered with, broad spectrum, gram-positive, gram-negative coverage. There are a certain number of special populations to consider that have infections more commonly of certain kinds. So, for instance, neutropenic patients oftentimes will require aggressive pseudomonal coverage. Most patients that have an indwelling port or a PICC line or something of that nature will require gram-positive coverage, specifically MRSA. Cystic fibrosis patients who come in with a flare of cystic fibrosis with sepsis, they do oftentimes get Staph aureus and Pseudomonas and sometimes worse organisms. And any patient that has multi-drug resistant and recurrent infections, oftentimes will require heavy gun antibiotics. It's oftentimes helpful to review previous culture susceptibilities. So for patients that get recurrent urinary tract infections, to review what their cultures have grown in the past to help guide your decision. And oftentimes you'll find that you'll have to use large gun antibiotics and consult infectious disease, etc. It's important to always evaluate the antimicrobials that you're using, and we should look at those daily and be considered for de-escalation when possible. If a patient has rapid clinical improvement, it oftentimes is appropriate to de-escalate to the most likely source in the first 24 to 48 hours. Empiric courses for culture negative sepsis, they're typically continued for 7 to 10 days. There's really no consensus on what the right choice is, but that seems to be often what is chosen and reported. And antimicrobial therapy, as is pretty obvious, should not be continued for systemic inflammatory response syndrome. For instance, someone who has a gout flare that has SIRS. So those sort of go along with sort of more of antibiotic stewardship and preventing the development of antibiotic resistance. Finally, source control should be considered within the first 12 hours. So if a patient has, an abdominal abscess based on CT, you should probably drain it sooner rather than later. Suspicious intravenous lines, so if a patient comes in with MRSA bacteremia and has a port, then you should probably get that removed as soon as possible. And they do recommend in severely ill patients to consider, the least physiologic invasive. So, if you have an intra-abdominal abscess, considering a percutaneous drain as opposed to an open surgical procedure is what you should weigh and consider, but favor more on the side of the least invasive when possible. And finally, in terms of general supportive care, these patients oftentimes do develop hyperglycemia, so blood glucose should be kept between 140 to 180. And all patients with sepsis should receive deep vein thrombosis prophylaxis based on guidelines. As we talked before, therapeutics not shown to have any benefit are things like steroids and activated protein C. So in summary, this was just a brief course on sepsis. We've gone through the epidemiology, the pathophysiology, and the microbiology of the disease. We've talked about the definitions of sepsis and how they may be changing, and the therapeutics related to sepsis. It's actually fairly simple. Fluids and antibiotics are the mainstays, and even though we've done an extensive amount of research, it seems that's the best that we can do at this time. And we have seen significant improvement in the mortality of the disease as we've documented it over the last 25 years. So here are my references, and thank you for your attention.